So I'm Catherine O. I'm the past president of the Ohio Psychological Association, and we just started having these Q&A sessions with Jim Broyles and Matt Capezzuto to help people cope with all the changes that have been occurring. So we did have a couple of these last week, and we're just continuing because there just seems to be such a high need for people to get their questions answered. So as we start the call, if you're able to mute yourself so that we don't have to hear the background noise, that would be great. And then when we get to the Q&A part, please feel free to unmute so that you can ask a question and get that answered. Great. So I'm just here to assist Jim and Matt, and so Jim Broyles is our person at OPA. He actually works on the staff at OPA and helps us with all
Professional Affairs.
Relevant practice issues. Yes, thank you, Director of Professional Affairs. And then Matt Capezzuto was invited to participate tonight because of his experience and relevance. So I'm going to let them introduce themselves a bit more and structure the session for tonight. Okay, take it away.
I'm Jim. I'm your Director of Professional Affairs, and one of my main jobs at OPA is to oversee and kind of gather information for you about what's happening in the insurance world, and then also to sort of advocate for you with our insurance issue. And so these last few days, these last couple of weeks have been very big for me because changes that are happening right now in the insurance world. And so I'm going to be talking to you about that in just a little bit. But Matt, why don't you just give him some background information? Matt's here to help us talk about providing teletherapy, and that is not an area really that I'm an expert in. And so it's so nice to have Matt here to talk about some relevant information for those of you who might be a little bit more new to the teletherapy world. You want to give them just introduce yourself, and then I'll talk a little bit about some basic information that I have.
Yep. So I'm Matt Capezzuto. I'm also exhausted, but so if I fumble around, forgive me. Kind of in the context of providing this teletherapy, getting our practice more fully and formally up and running than we had initially planned. But a lot of therapists were kind of hesitant to get into it, but now they're saying, hey, this change has caused me to see the benefits of this, which is why we're doing it. We were doing a little bit of it with our prescribers, but we were going to formally launch our arm in about 6 months, but we decided to go ahead and do that now and get everyone trained. And we're working our way through the process. Some of us have more experience than others, so we're doing like an internal consultation group. Hopefully we'll start one of those with OPA. And I've been basically providing about now 50% of my services through telehealth. I own a pretty decent sized private practice. We have several locations throughout Ohio. We were doing it location to location, but now we're doing it from home to home in every possible scenario. So we can basically continue to serve our clients because, we're in the type of healthcare, obviously, where we can't just abandon patients. We can't just cancel appointments. We have to continue to serve them. So that's why the teletherapy has been greatly beneficial. And some of the hesitance is around the laws not having caught up yet to the technology. So hopefully we can talk about some of that stuff tonight to ease people's anxiety about it.
Great, thank you, Matt.
And I also serve on the committee with Jim. We're on the insurance committee together.
Wonderful. And I just want to encourage folks, if you're not muted, go ahead and mute. We can hear you typing pretty loudly, and it's easy to hear background noises, so thanks.
Where the Zoom application, if you take your cursor down to the lower left-hand corner of the screen, you're going to see a little microphone down there and it says mute right underneath it, and you can mute there. Also, if you're on the phone, then we're asking you please to mute your phone. So I want to just give you an overview of some of the changes that have been happening right now. And then Matt's going to talk about a little bit about some basics regarding telepsychology. But we really want to allow this time to be a time for you to be able to ask questions. So we're going to leave lots of time for that. I'm just kind of going to go through everything first, or some of my remarks first, and then we'll make sure that we're leaving lots of times for questions. So there have been a lot of changes going on here in the last couple of weeks. And, you know, the changes that are happening, what really is affecting our practice for most of us in so many ways are rules and regulations that come from everywhere. They're coming from the federal level, they're coming from the state level, they come from, you know, our state board of psychology, they come from the laws that affect Medicaid and Medicare, and then they're coming from our insurance regulations. Each individual insurance company has its own specific regulation. If you're contracted with that company, then you know you have to actually follow those regulations too. And each one of those is connected to the other. And every time there's a change somewhere, it's affecting everything else. So it's like it's very difficult to sort of track all of this and try to understand what that means for your everyday practice. One of the things that I know is true is that because these changes are happening so quickly and because everything affects everything else, and for some of these circumstances, there's not a real clear, definitive answer. And I know as psychologists, we don't like that, but I'm going to try to give you the very best guidance and guidelines that I know, that I'm aware of. I can tell you this, that right now, as I communicate with, you know, people on a national level, people here in the state, I've got some pretty good contacts with most of the big insurance companies, and I'm hearing and seeing a lot of an atmosphere of just real mutual support happening among all of these different entities. And that in some ways is really encouraging. And, you know, there's an overall just sort of atmosphere of, you know, just asking us to make a really good faith effort to abide by the spirit of the laws and the rules, and a lot of understanding that it's very difficult for us to, you know how to proceed, you know, with some of these circumstances. I'm making my very best effort to learn and update as I go. Okay. And so I'm posting all of my information that I receive. It's going out in regular updates, and I'm hoping that you're receiving those. So I'm sending my updates out on the listserv, and then they're being emailed out to all the psychologists in Ohio. And then my updates are also available on our OPA website. And right now on the OPA website, we have a resource page, you know, giving you all kinds of resources for how to adapt to this crisis. And then I have my own separate blog page, which has all of my updates on there. Everything, I think I've done 5 so far. All of the updates that are dated March 16th and more recently are the updates that are most pertinent for everything that I'm talking about right now. So when you signed up for this, you should have received a handout that with a link on it to our resource page, a link to my blog, which has my updates on there. And that also has should also have my email address. And please feel free to reach out to me through email if you have specific questions. The one thing that I'm really asking everyone to do right now is please read through the updates before you reach out to me with the specific questions. Because sometimes I'm receiving questions about things that are covered in the updates, and that just really helps out the time that I have to spend, continue working on gathering information and getting you the best information. We also have right now a lot of new developments happening and information flying in all directions. And so there's a tremendous risk. I posted a little bit about this earlier today. There's a tremendous risk for misinformation to happen. So what I'm suggesting that you're doing is if you find out something new, a new development in some area, the best procedure is to send it directly to me, and I'll do my very best to vet that information and to get it out to everybody as a part of one of my updates. So one of the most important things for us to think about right now, all the current Board of Psych rules remain in place, just as they always have been, and the board's obligated to enforce those. Our Board of Psychology continues to consider telepsych, provision of telepsych as a specialty area, and they are asking us to consider that in order to be able to provide services in this area, that you have some kind of specialty training. Now, having said that, I will add that the board doesn't really give very clear guidelines on what that training should include. It's just saying you need to understand some of the basic important points about telepsychology before you just hop into this area. And there's a lot of different resources. Right now, APA is offering some, I think it's 4 2-hour webinars for free online. And I believe there should be a link to that on our resource page. So that would be a great place to start with getting your telepsych training. I believe I included in one of my original updates, and it's posted as a part of our resource page, the basic important areas that any kind of telepsych training should be covering. So if you're looking at something and you want to get some training and you want to get yourself up to speed, if you're just looking at some of those areas that are important areas to cover, that gives you an idea about whether your training is good training to have right now. Okay. Board of Psychology has said to us repeatedly, your first and most important priority right now is to provide for your clients and reach out to them. That is the highest priority. And so if you're seeing to that, then you're doing the most important thing that you can be doing. Right now, the Federal Office of Civil Rights and the Department of Health and Human Services, who are the entities responsible for enforcing HIPAA, have relaxed some of their enforcement over the HIPAA rules as they are connected to providing services through a telehealth platform. So in other words, the HIPAA law up until now has been saying, that if you provide any kind of teletherapy service, it needs to be through a HIPAA compliant platform. And the laws that affect the enforcement of that have been relaxed. And I'll just go ahead and read that to you directly so that you can hear it. And this is directly from the website for the Department of Health and Human Services. During the COVID-19 national emergency, which also constitute a nationwide public health emergency, covered healthcare providers subject to HIPAA rules may seek to communicate with patients and provide telehealth services through remote communication technologies. Some of these technologies and the manner in which they are used by HIPAA covered healthcare providers may not fully comply with requirements of the HIPAA rules. The Office of Civil Rights will exercise its enforcement discretion and will not impose penalties for non-compliance with the regulatory requirements under the HIPAA rules against covered healthcare providers in connection with good faith provisions of telehealth during the COVID-19 nationwide public health emergency. This notification is effective immediately, and that came out last week. So our attorneys at APA have taken a look at this, and they've done some interpretation for us. And the main message they have for us is this: if you are making a good faith effort to connect with your clients through a telehealth platform, and that platform is not available to you for some reason, or it's not, you're not able to access that for some reason, you may move on then to other platforms that are not necessarily HIPAA compliant. Okay. In general, insurance companies are scrambling right now to revise their policies, and the revisions continue. They've been going on even through the beginning of this week. And I'm trying to update all of you as you go along. So many have had, many of the insurance companies have had more stringent guidelines in place up until now. And they include things like, hey, you have to go to our webpage and attest that you've received the training. You have to use our already designated therapy platform. And so the restrictions like that are being dropped. In many cases, they're not requiring you to adhere to those procedures. And I'm giving the specifics in some of my updates that I've given you. Most of the insurance companies up until now have been requiring that teletherapy provided through a means that includes audio plus visual, okay? And again, as of today, most of those requirements and most of the major insurance companies have been dropped because they are recognizing that during the crisis, many of these telehealth platforms may become overburdened, and I've actually heard that some of them may be crashing. So, and then they also recognize too that many of our clients may be homebound and don't have access to the latest technology. So because of that, they're dropping that requirement for it to be visual plus audio. And again, if you've made your good faith effort to connect with them, most of them are, through the appropriate means, most of them are saying now you call them on the phone and you can do your therapy sessions on the phone. Now, Medicare has not gone that far. Medicare has relaxed some of its requirements. So Medicare has said up until this point that only certain of their Medicare recipients may receive teletherapy. And they need to be certain Medicare recipients who are located in certain rural remote locations, and even then they must be in their doctor's office to receive the service. They can't actually be in their home. So Medicare has relaxed those requirements. And they're saying at this point that any Medicare recipient may receive teletherapy. However, they're sticking with their requirement that it must be visual plus audio. And so that requirement still remains in place. And there's been a lot of questions and a lot of concerns about that. I'm concerned about it too. I'm concerned that many of our Medicare recipients don't have the sophistication to be able to benefit or to be able to access, through more sophisticated electronic means. That they certainly would be greatly benefited if we were able to reach them through phone only. But that Medicare is saying you cannot bill us for that at this point. Okay. Now, to further complicate this, it's a good thing to remember that for Medicare Advantage plans, and that's the Medicare plans that have been contracted out through places like Aetna or United Healthcare. Those Medicare Advantage plans have the latitude to be able to allow for things that regular Medicare does not. Some of them, I believe, like Aetna, are saying, hey, we're just going to go with the Medicare guidelines. But some of them are actually relaxing their restriction. And I believe United Healthcare is one of them, saying, hey, you can't call people on the phone. So again, Medicare Advantage plans are different than just the regular, they can be different than the regular Medicare guidelines. So that's just an overview of the important things that I want to say. And once we get to the question and answer part, if you've got some specific questions about some of the things that I'm saying, I'd be happy to talk to you about that. You want to talk about your end?
I'm sorry, Jim. Did you ask if I wanted to say something?
Yes, your turn.
Thank you. Yeah, so basically the way I'm looking at this is kind of the overriding principle here is the law has not yet caught up to the psychology or to the technology. So we've been thrust into this position where we have to kind of make sense of all that, and we're effectively operating in, I guess you could say, a gray area because there are no direct answers and it's a moving target. The interesting thing is, just as much as this has thrust us into having to do this maybe prematurely, and we have to face our discomfort, so does the legislature. They're trying to make the laws, the federal laws are changing, the state legislature they're trying to push laws through and find ways for this to happen. So I have a feeling that the kind of silver lining in all this is there's going to be less of a gap between the law and technology, which then will allow us to fully utilize the benefits of telehealth. So I think a lot of the questions are going to understandably come about the gray area because we're doing this maybe prematurely, maybe we were not going to do it at all, but we don't have really a choice now if we want to continue to serve our patients, especially if the governor says everything's shut down, so it's a reality that we have to face. So as much as I can help you with the experience I have with writing our agency policies, with implementing them, with fast tracking the rolling out of our program, anything that has come up in between, anything I've heard from my staff about their complications, things we've worked through, that's what I'm here to do. Hopefully I can be of some benefit to you. But just not to complicate what Jim said, as much as the enforcement of the rules are being relaxed, we still can't be cowboys out there. We have to use common sense. And if you are going outside what the general rules are, even though they're not being enforced, I would just document your rationale for doing that every single time you do it. That's really it.
Okay, so this is our question time. What questions do you have?
I have a question. When you say document everything that you're doing, just make a note that you're using whatever platform you're using because of the COVID crisis and patient is reluctant to come in. Is that
Absolutely.
adequate?
Yep.
Okay.
You know, Ron Ross with the Board of Psychology and I were just having a conversation about this the other day or today. And so he was saying, like, just document that, hey, I tried to use this platform. It really wasn't available to me, so I had to move on.
Mhm.
You're just documenting.
Mhm.
And even if that's in a progress note, you know, that's where I would document it because it's all in the right place.
Mhm.
This particular client, you know, only has telephone only available to them.
Right.
I've had clients who have been trying to, you know, sort of set up an electronic connection, and at the last minute, it didn't work out. Hey, I've got to download this. It's not downloading for me.
Right.
I can't make that connection that way. You just document that.
Uh-huh.
And it's important to remember we can't predict every possible technical glitch or every possible barrier. You can think of many, many of them that could potentially happen, but when that one happens that you're not prepared for, you just have to be flexible. And I know that, like myself, being obsessive compulsive, no one here can relate with that. That's difficult.
And so here's the question about billing. I mean, if we have started using telehealth or using different platforms in March and we bill for telehealth, any idea whether that's going to be paid for or not?
Yes, that's why I'm saying the many insurance companies are relaxing their guidelines so it will be paid for.
Okay.
Now, all of them do tend to be saying right now at this point, you know, some of our plans, I think it's sort of like their, you know, their disclaimer. All of our plans don't necessarily cover, you know, cover telehealth because some of them are, you know, are self-funded plans and they can do whatever the heck they want. And so they just say it's a good idea to check benefits. But for those that are probably, you know, that are main plans that we offer, you know, these guidelines are relaxed and we are covering that. Many of them are covering that.
I do recommend checking benefits though, because, you know, you're better safe than sorry. And even if you're not going to get paid, at least it's good to know that.
I had two questions. One is when you are checking benefits, I just assume that people are now asking specifically about telehealth.
That's right.
But the other question is, whatever they say, has anybody gotten paid yet on this call from an insurance company for telehealth?
I've heard people actually getting some payments. Yeah.
Yeah.
Anybody else want to chime in on that?
Jim, I think
I can chime in.
Yeah.
Oh,
I was going to say, I think a couple have come through for me, although I'd have to look in more detail. I did want to make a point to be added, which is that, again, it's very plan dependent, but most of my stuff is workers' comp, but they have it's important in the billing to note that it is telehealth. Like, in other words, for workers' comp, it's 90834, 90837, but there is a facility code. So it codes as telehealth as in the method of delivery. So you want to make sure if that is the type your billing system you're using, that you're not giving the impression you're doing it face-to-face in the office.
So that's a really good point, Dave. So I've had a lot of questions about the specifics of the billing. Okay. And so when your claim goes in, it actually says it shows right on the claim that it was a service delivered telehealth. Okay. And there's been a lot of questions about this. First thing to remember, CPT code that you're using is the same CPT code that you have been using for face-to-face service. Okay. But there are some additions. One is place of service, and the place of service should be 02. That's signaling that's just a code that's saying this was provided via teletherapy. Okay. And then the other is the, what's that word I just keep forgetting all the time, Matt? It's the
modifier.
Modifier.
95.
My brain is so full right now. And then the other thing goes right behind it. Modifier should be either GT or 95. GT or 95. So that is all together on that one line. If you're doing the actual claim form itself, those are all together on one line, and that's signaling them that this was provided through teletherapy. Now, I've heard a lot of questions, and there's a lot of misinformation roaming around about you use one modifier for audio only and another one for visual only, and it's like none of that is true. It's either one of those modifiers will work for billing teletherapy. Some of the insurance companies are specifying one or the other. Most of them are specifying GT, okay? But the standards for coding are actually uniform across the industry. So either one of those should work. And what I would suggest is try the GT, look at some of the updates that I'm giving, because some of them will tell you which insurance companies are requiring the GT versus the 95. But I'm also suggesting too, if you try one and it's not working, then do the other one.
What's the difference between them?
I don't know.
Okay.
Those are the mysterious insurance rules that they don't tell us about.
Okay.
Right. There's no, people are wanting to know the difference and they're assigning differences to them, and none of that's true. GT or
What does the modifier 95 mean?
it means that you're delivering teletherapy services.
Oh, okay, so it's O2 and then either GT or 95, and that all means delivering teletherapy services. Okay.
Right.
And I have one more question too. I know he's here tonight, but I read something Dave Schwartz said on the listserv, and like others, I have a concern about Medicare and the delivery of services with just auditory and not visual. And what I've been doing is documenting that this was telehealth and that the patient does not have access to electronics and can only receive services in this manner, and then go ahead and see them, because like you said, our first directive is to reach out to the patients. I may or may not get paid, but I do document that they don't have the means to do both auditory and visual telehealth.
Right. Right. Yeah. I mean, you can do that. I just can't sit here and tell you that Medicare is going to be okay with that.
Right. Right.
You know, unfortunately.
So Jim, kind of along those lines, I bet some people are wondering this. Should you not even bill Medicare then? Or would that be fraudulent if you were to bill?
Yeah, right. So that's a really good point there, Matt. I mean, if you're sending that in and you're saying, you know, hey, I billed this through teletherapy, but you know, you're not delivering that according to their guidelines, you know, technically that's, you're not actually following the procedure that's billable. So I guess what that means is, you know, if someone does an audit of your records and you have that fact recorded in there, then they may say, hey, you didn't deliver a teletherapy session, and we're going to, you know, ding you on that we're not going to reimburse for that. Now, honestly, my opinion, if they go that far, that's pretty petty. We're in a time of crisis right now, and they may not, but they're still not coming forward and saying, we're going to greenlight that.
Mm-hmm.
I have a feeling they're getting enough heat. Maybe it will never be enough to change that rule.
It's just shocking because they're one of the vulnerable populations.
Exactly. It makes no sense. But what do they do that makes sense? Yeah.
Right. So, okay. Thank you.
Yep. I have an interesting situation that I experienced just today. A Medicare recipient, I believe she might have one of the commercially managed ones though, so the managed care might allow it. But I had most of my session with her through video, and then it didn't work, so we did the dial-in. Our system has a dial-in option that's still a secure line, so we did that, and we figured out how we'll do it next time. And so I don't know how I'm going to build that. I got to research it.
Maybe you can post it when you do decide.
I will, yeah.
I'll
update you.
If you're on Zoom video, if you take your cursor down toward the bottom of the screen, you'll see a chat button. And if you push that button, the chat feature will pop up here over on the right-hand side. People are asking questions and also having some discussion here too. Someone asked the question of recommended video conference platforms, and then there's been some responses there that are you know, telling us about like some things that people are using.
Yeah.
Doxy and VC are both ones that I've heard that are free and good.
But be careful with the free ones, everyone, because they typically don't offer a BAA. Although that's going to be a rule that's not really enforced right now, I still think it's important to think about that.
Right. But for right now, it's an alternative.
Yeah.
To get through this. Google Hangout is another one, which I think it's part of the Google Suite services, which you pay for.
So we just, I'm at Cleveland State University, and all of our 19 of us are using telehealth the last 2 weeks, working from home, and we just got access to Zoom for healthcare, which is the HIPAA compliant one. It does have a BAA that our general counsel reviewed, so we're pretty official to move forward even past the crisis with that.
And Doxy.me is good. We've used them before, but the paid version, I don't know, I think someone's saying that the free version does have BAA. Just check. We're using secure video, but I actually got a list from my insurance company, the American Professional Agency, of a ton of them. And they're like, they go in like a list of these are approved, you might want to consider these, and these are options during the crisis. I can forward that to you, Jim, if you want to get it out to everyone.
Okay. We'll get it to, you know who, Matt, send it to Karen Harden and just ask, go ahead and post that on our resource.
All right.
Resource page. Matt, somebody's asking which teleconference platform you prefer.
Well, we use secure video, and the reason we're using secure video is because in the very short few months, it'll be integrated into our EHR system, so it will eliminate a step of having to do double screens and all that. So that's why we're using that, and we actually like it. It's pretty nice. I did like Doxy.me too. It's fine. It's just personal preference, and you know the price and all that. You just have to weigh all those options. Zoom does have, like you were saying, Catherine, it does have a telehealth platform. The secure video uses the Zoom widget, but it doesn't go through Zoom. It goes through their secure system. As long as it's HIPAA compliant, like after this is done, they all pretty much offer the BAA in the paid version.
Someone was asking, is this Medicare's final decision on all of this? You got me. I don't, you know, they're a mystery. What they do and how they do it, it's just wrapped up in bureaucracy. But if you're really interested in this issue and are concerned about this issue, I would say reach out to your congressional representative. You know, your representative in Congress, your senator, our senators, you know, and just say, hey, we need help. We have some people who are Medicare recipients who need help. And our current restrictions are not going to work.
Yeah. Jim, you know, for what it's worth, I just got a phone call a couple hours ago. I was in communication with the medical director of BWC following up some of our efforts. And they are saying at the present time, their intention is not to pay psychotherapy rates for telephone only. In other words, you know, they reimburse telehealth at the psychotherapy rates, but they're saying they're still going to require that be delivered by video, audio combined. And if it's audio only, then they do have a code for like a phone consultation, but it literally pays less than a third of the psychotherapy rate. So I think that's going to be, and again, I'm sure that's not his call. It's probably what is being told higher up. But again, that may be something that we have to approach more politically because again, the same issue applies. Just a high percentage of the people are not technologically sophisticated, don't have computer access, don't have smartphones. So,
but how are they going to know that? Because if you code O2, it comes up as telehealth. It doesn't say video or audio only or video and audio. It just says telehealth.
Right. That's correct.
So it's the honor system, and you'll have to, if you get audited, then you'd have to answer for that. So that's basically it.
So what Dave was saying, that was for workers' comp.
Right. And Dave, so the phone consult, just to be clear, is less than VWC's rate. I'm not sure how it compares to the other rates. We're probably not supposed to be talking about rates, but you know.
Well, let's just say it is considerably less per minute or per hour reimbursement than it is for the psychotherapy rates, which has never made sense to me because it's an hour of your time. you know, again, I certainly wouldn't ever encourage anyone to do anything illegal or unethical, but
No.
there is an old saying about don't ask, don't tell. For what it's worth, I've had some of the same experience you were mentioning, where starting a session under two-way video, at some point during the session, the video degrades and audio degrades to where we pick up the cell phones and go to plan B. Now, do you split the charge, or basically in my case, I'm not the best record keeper, so I'd already written my note that it was teletherapy, and that's probably what'll go through. Not that you heard that from me.
So my hierarchy is this: no matter what happens, I got to help this patient. So if I have to eat it now and then, that's what I'm going to do. You know, it just is what it is. And then if things change and we can bill retroactively, but like for example with Medicare, then that's what we'll do.
For the record, Matt and I are part of a coalition right now that works with other behavioral health providers, social workers, clinical counselors, psychiatrists, and we are working directly with the big insurance companies right now to give them feedback about our experiences. So we'll be looking back at all of this and how it all shakes out, and what worked and what didn't work, and our, you know, any concerns that we have about you know, they're making money off of all of this, and we will definitely be giving them feedback when all is said and done.
Come to think of it, Jim, these might be good sessions to have once in a while just for those issues.
Yeah, right.
Yeah, I have some more questions, but I don't know if other people are as interested in these. I just got all my staff starting to do telehealth very quickly, you know, getting online training, reading the laws and the most recent guidance, and piloting our tech and getting it out there. So we've had a lot of challenges, and it's been really tiring. My staff are saying that telehealth is more tiring than they thought it would be. I don't know if it's just because we're in this time of intense change and we have to learn it quickly. You know, Matt, do you feel like your telehealth sessions are more tiring than in person, or what's different about it for you?
So I can speak personally for myself. I said earlier, I'm exhausted. I can't tell you why, but I think some of the factors you identified are part of it. But I've been like working nonstop. I don't even know what day it is half the time, with emailing my staff, training my staff, answering questions. So I think that for me, that factors in. But the other interesting thing I've noticed is with some of my patients, of course, I could have predicted this. It's been a little more difficult, but with others, it's just flowing like it's normal. But no matter what happens, I start the session with talking about the change in venue, if you want to call it that. I check in about halfway through, and at the end, I ask how it was for them. And I keep that going as kind of grist for the mill, or the teletherapy mill, I guess you could say, because I think it's very important. And good or bad can come from that. More material can come from that. But clinically, there is a wide range of issues that I think we could talk about all day, that maybe we have another call for that. Because I'm really keeping my eye on the clinical differences, you know, facilitative or not, with this whole process. And as I accumulate feedback from my staff, we're gonna be basically talking about that, flushing things out in our consultation sessions.
Great, thanks.
If I could add in, I would say that I have definitely found them more tiring than normal. Again, there's a lot of extra factors. This isn't the only factor that has changed, but I was very surprised at how mentally tired I was at the end. And I'm like, wow, I don't normally feel this way at the end of a long day. So I can't put my finger on it either, but I have definitely noticed a change.
Well, think about all the different stimuli changes that we're having. You know, we give all of ourselves in sessions. We're listening, we're sensing, we're seeing, you know, whatever. But with technology, it's just another third party, kind of third thing involved. So, you know, and then you have to be concerned, kind of back of your mind, you're thinking about, will the technology fail? What if it,
Yeah.
you know, so all these things going on, and we don't know yet. We're going to flush all this out. That's why I think it's so important for all of us to bring this stuff to the table once in a while and talk to one another, because then we can maybe, you know, kind of develop best practice standards around those things. This is a whole new field, even though we're doing the same thing. That's why I think the board is smart in saying it's a new competency, because it really is.
Matt, I think your point is so well taken. And I think the idea of maybe as this goes on is doing some training sessions or feedback and sharing sessions focused on the clinical side.
Yeah.
Because I think, you know, again, I am seeing the same thing that Meredith was seeing fatigue wise. And it's interesting. I was telling several patients, because I'm realizing I'm having a harder time remembering what we talked about in the last session than I normally do. And I'm also seeing more bleed through from the patient I just spoke to and the patient I'm speaking to now. It's like something, and there's some lack of data that normally cues my memory that is covered there. But as I do tell patients, from what I have seen in the literature, and I was to some of Ken's classes and so forth early in the development of the telehealth standards, there is a lot of data that is far from conclusive as to which is, quote, better, unquote, telehealth or face-to-face therapy. And it's somewhat dependent on age and people's experience and so forth. So as I tell people, that's a fascinating discussion to have. But if you reframe the question to what's better, telehealth or nothing, it becomes a very simple question. Mm-hmm. And since for many of our people, that's the question they're faced with, we're just sort of having to learn on the fly. But yeah, I had like one of my really long, 8 patient days, and I was like face down on the desk at the end of the day and just not moving. I'm normally not that tired. And I'm not trying to rewrite the system for 15 other people either.
Any other questions? Comments?
Well, just a comment. My building is about 10 minutes from my house. And not until now that I realized how important that 10 minutes was. We cross a river, maybe that's symbolic somehow, but that's all it typically takes for me to feel like, okay, I'm done with my day. It all runs together. I'm working out of an empty bedroom, which I'm sitting in right now upstairs. And when I'm done, I walk down 12 steps. And it just doesn't feel like enough. And I completely agree with the exhaustion thing. Last week was a poop storm just because of signing up with DoxyMe and all that stuff. But now that the administrative stuff has slowed down somewhat, I'd say maybe 40%. And these days still seem really long. And what I'm missing, we have a group, there's 7 of us in our practice, and it's just a great group of people to work with, and I don't get to see them. So there's no processing in the door jam about what's happening, and I feel like I'm on an outpost here, and it's still winter.
Yeah, well taken. Today I had an experience. I'm still seeing some patients face to face, the ones that really just aren't ready for this. And I go into my office and very few people are working, and it felt like a ghost town. I'm like, man, I feel lonely in here. It's like you said, I can't go talk to other people. It's very weird. And seeing, I'm noticing that the carpet needs clean and all this other stuff I would never notice before.
That's the worst part.
Yeah.
It's really interesting because I also have been going to the office some because I have some patients who want to come. And I think that there's something about, and it's exactly what we're talking about, that actual face-to-face contact. And there's also something I think about sort of being at the office, which when I don't go, when I just do a bunch of telehealth sessions from home, feels so different. It's not that it doesn't feel professional, but in a way, it sort of does. I mean, I've heard people say if you're doing it from home, you don't get dressed in the same way, or I did a telehealth session with a young woman who had been sick, but she ended up at her session in her kimono, and wow, that's casual.
I think some of the fear too is that the therapist is going to think that the patient will get to know more about them out of their control, like what color paint they like, what their carpeting looks like. But the one thing I think that's important to remember is we're all, of course, conscientious of boundaries, but sometimes you can be so rigid with that kind of stuff and miss an opportunity for letting them know something about you in a professional way that helps facilitate the process. For example, some patients, they don't really want to talk to you unless they know something about you, whereas others, they want to see you as a real person, whereas others want to see you as the guy behind the screen, who has all the answers. So it just depends on the patient, and all of those factors have to be considered when you're delivering service like this. So, I mean, regardless of what we believe, your patients are going to know something about you just by being in the room with you, whether it's at the office or at home. So to resist that might actually not facilitate therapy. Now, of course, you're not going to disclose all over the place, but you can, there's a whole literature on self-disclosure, controlled or uncontrolled, and you can read about it. One of the best writers on that topic is Irvin Yalom. He's fascinating. You should, if you haven't read any Irvin Yalom, I strongly recommend it. But, that's a fear I think that we have sometimes. We want to make sure that we're maintaining good boundaries. And we all do that, but sometimes that can become confusing what that is. And it's all right if your patient knows what color paint you have on your walls. Now I'm trying to do a lot of my teletherapy from the office initially, but now I'm not. I'm just going in, I'm still doing it there in between face-to-face patients. But this is all something that has to be fleshed out.
Yeah. By the way,
Yeah.
we're all admiring your ceiling, by the way.
Thank you. I appreciate that. It's better than you seeing what I have in here, and this is not where I do teletherapy.
I wanted to say that I went
gym.
into the office last week, and I did telehealth, but I went into the office, and it was different than staying home and doing telehealth.
Yeah, it's
It
different.
was the same service, but it was different. And I concur with everybody that has said how exhausted they are. I also spent an enormous amount of time on Sunday night deciding where I was going to have the computer and which part of the house they would see. You know what I mean?
Yeah.
And also, I wanted to say, I've enjoyed this conversation tonight, and I think there's a lot of experience on the screen tonight. And I really like the idea of maybe coming up with like best practices part 2 or something, because what I'm hearing now is that this coronavirus could be cyclical, or it could abate towards the summer and then come back in the fall or something. And if it does, maybe by that time we'll have some best practices part 2 in place, because I think we're all gaining a lot of information about the clinical, the administrative, the electronic billing services and all that. I think I would definitely, I would be happy to even be a part of developing best practices part 2.
Matt, don't most of the really good trainings have some best practices guidelines?
They
already?
do, yeah. So what we made our staff do is like the training that is accredited by APA or whatever, OPA, that has, basically what they would call an educational certification. So I did mine years ago with TBHI several years ago. Now now that is online, and that I think is the one that APA is giving for free, which is a gift. And the Zur Institute has a pretty reasonably priced one, and I'm getting feedback from my staff, and it's good too. It's covering a lot of the same information. But a lot of those best practice standards are in there. But what's not really in there is those best practice standards in the context of the clinical side of this, which obviously is the most important thing, in many respects. And not only is it going to be important for a potential second outbreak or whatever, or a lingering, virus or whatever, but in the future, I think from this experience, we're all going to learn that this could be very beneficial to people who have issues with getting to the office, transportation, money, agoraphobia, whatever it may be, injuries, illnesses. So why wouldn't we want to help them through telehealth? It's going to expand your practice. If you let it, 5 years ago, I said every telehealth will be 20 to 30% of every practice if the law catches up with technology. And I think we're going to be there.
Looks like we've got some questions over here for on e-signature services. I know that a lot of people are needing to get consent forms out and sent back, and there are web-based services for getting e-signatures. Matt, do you have any feedback about that?
I do. I think the question was, do you need a BAA to have e-signatures? If
Right.
that e-signature is going to a third party, for example, ours, we have several different ways we're having people sign their informed consent. One's through our patient portal, through our EHR, one's through mail, and one is through the teletherapy platform. If anything with the patient's name or PHI is going to be submitted to that platform or housed there, you have to have a BAA under HIPAA rules. Now, I can't speak to whether or not that rule is going to be the one that's not enforced because of the changes, in the crisis. But the answer to that is yes. Anyone who has access to your patient's PHI must have a BAA signed with you.
I've been having a lot of confused information flying about the specifics for some of the insurance companies. So, for example, I've been putting out information about updates for Anthem, Blue Cross Blue Shield. And what I'm hearing from many of the psychologists is that when they call Anthem, the representatives are giving them different information than I'm sending out about what the regulations are. And so I'm in direct communication right now with a network manager who's overseeing all of this. And and what I can tell you is her information to me has been consistent. And I think part of what is happening is that when you reach out to the phone representatives, they're not always updated on some of these new their new internal company regulations. So that can be confusing. And what I can say is that the information that I'm sending you has been vetted by that company. And just like we have with, everyday situations with insurance companies, the phone reps that you talk to don't always have the most up-to-date information. I know that's confusing and I'm sorry for you, but I guess what I would say is I urge you to just try to count on some of the stuff that I'm sending out.
Jim, apply that to any single insurance topic and you'll get the same answer.
Right.
A lot of times the people answering your questions aren't informed.
Right. And again, I was talking a little bit ago about our coalition that Matt and I both are a part of with the other behavioral health providers. And that's one of our main issues that we're talking to with the insurance companies right now is like communication. The people that we're reaching on the phone aren't always the ones who are the most informed. They're not always up to speed.
Jim, I've got a question for you.
Go ahead. I'm sorry. Go ahead.
Yes.
This is not a question that has come up tonight, and you may have covered in your previous sessions. I haven't had a chance to listen to those yet. But for those of us who practice around the edges of the state, I'm in Cincinnati.
Right.
A lot of our clients live either in Indiana or Kentucky, and I know I've been, following the conversation on the listserv about the frustration that we have all had in trying to just reach the legislative office or the licensing offices in the adjoining states.
Yes.
And I've tried to go through the hoops that have been printed by Indiana and Kentucky with absolutely no success thus far, because of course they've sent their employees home. And
right.
So
are you following the emergency? I mean, many of the states are establishing emergency procedures. Do you have access to those?
Well, I've been getting this is Lynn again. I've been getting, for example, the Indiana COVID updates.
Okay.
They provide them about once a day, and then there's a section for providers. And there has been not one single statement about provision of psychological services, except for a couple of nice resources for handling anxiety and stressful times and that kind of thing. So I've not been able to connect with live people. And in Kentucky, I've sent the documents, I've sent proof of licensure. It's gone into, I sent it by snail mail because none of the information that they had on the website was correct. Their fax numbers were wrong and they just weren't updated. But I'm just wondering, Jim, if anybody's had I'm assuming I'm just, of course, just providing the services, and I'm going to file the claims as with anything else. And I'm assuming, like, if I don't get paid, then I don't get paid.
Right.
But I don't want to be breaking a law.
Yes.
Either.
Right.
That's my,
This is a really, really good question. And so what I would say is, under most circumstances, typical circumstances, we are not permitted to practice in a state where we are not licensed. And for those people who are living or practicing near our border, this is an important issue. Because, for example, folks from Indiana were crossing over the state line and seeing our psychologists in our Ohio offices. Now they're homebound, and technically, legally, we're not supposed to be having telepsych with them in their Indiana homes. So in order to address this, many of the states are creating emergency licensing mechanisms and procedures. And there's an effort right now to post those, in a central place. In one of my updates, I actually give you a link to that central place. It's through ASPPB, where you can access on one web page all of the emergency procedures that are available for the states. And just a second, as soon as I finish talking here, I'm going to go back and look, Lynn, at Indiana to see what might be there, just to make sure you have the most up-to-date information. But when I checked Indiana at the end of last week, I believe we were all having a hard time communicating with them. I'm a part of a network that's with the DPAs across the country, and we exchange information with each other. Indiana doesn't have a DPA, so they're sort of out on their own, and we didn't have a good link with them, so I don't know what's going on there.
Yeah, my last information with them was that it was a 30-day license for $50.
Right, okay.
And so Kentucky waived their $50 fee, but you still have to do the application and the attestation and documentation. Lost in the nether regions at the moment.
That's a real relevant issue, especially for the folks down in Cincinnati, for our psychology in Cincinnati. So earlier, in a second, I'll go back and look at Indiana.
Okay, thanks. Yeah.
I was having a conversation earlier today with Ron Ross, the executive director of our Board of Psychology, about this issue with Kentucky specifically. And so they do have some emergency procedures in place, but they still are very slow in being able to process applications. And they're saying, hey, you're going to be, we need to be approved first for this so that you can practice there. And Ron said that he was having a conversation with somebody, in Kentucky, and they were having a hard time being able to understand the relevance of changing this law, changing their laws. They didn't understand, they were having a hard time getting the idea that this is to maintain ongoing therapy relationships that are crossing states lines now that they're homebound. He was bringing that up, and that sounded like that was a new understanding of that circumstance for them. So whether that will change their procedures or they've got time to change their procedures, I don't know. But here is what he said to me with the Kentucky issue. He said, for you, if you are an Ohio psychologist, for example, and you're providing a service to someone in Kentucky and you're not licensed to provide, in Kentucky, then your highest priority is continuity of care and to reach out to that person. And if somebody, really wanted to prosecute you for practicing without a psychology license in the state of Kentucky, then they would have to actually go through the process of filing a criminal charge and all of that, and would actually have to go through the Board of Psychology. So he was saying, document every single effort that you have made to contact that Board of Psychology and the circumstances that you're in right now of trying to connect with your client, document all the barriers that you've come up against, and then proceed with your client's interests as your highest priority. That's what he said. Again, it's back to, we're in some very difficult circumstances right now, and documentation is part of what you need to do.
Yeah. Jim, I would add to that.
Thank you.
Yeah. Jim, I would agree. Lynn, for what it's worth, I'm also in the Cincinnati area and have some of those same issues. And, what I have decided is if I don't get a response, again, everything's documented, and essentially go for it. Let me go back a step. There's a phrase you're hearing from, the state medical board, others insurers. It's all the same phrase: for the duration, for the duration. In other words, recognizing we're in unusual circumstances. And speaking to the director of the BWC, state medical director, he said he had been in contact with the state board of medicine about multiple issues, and the general consensus is they're going to not be looking to hang people for bending rules when there simply is no option. Just as an example, the state board of medicine is going to allow refill of opiates without a face-to-face visit, which is against their own guidelines right now, because it makes absolutely no sense to make a stable patient leave and go to the office and then go to the pharmacy. So, they're going to be flexible on some of these rules. I think it does speak to the fact I think Jim's point is very well taken, and I think Ron is giving excellent advice. Document that you have attempted to do so, that it's in process, and then meet your obligation to take care of your patient's needs. And the likelihood that they're going to come after anybody is, I think, basically zero.
Our government and legal leaders are not going to come out and tell you, hey, it's okay to break the law. They're not going to make statements like that. But, many of them are saying it would have to be a really extreme, person who's clearly taking advantage of the circumstance in order for them to be held accountable for that legally. Lynn, I just went back and looked at the ASPPB website. That's where all the states are filing their emergency orders. Indiana still has nothing there. So, you know, what I think is they probably actually haven't had any emergency orders updated, which is sad.
Thanks, Jim.
Mm-hmm.
I have a question. So I'm starting to get some insurance companies corresponding with us to say that they are waiving copays, co-insurance, and in some cases even deductibles. Are you seeing that with a lot of the major insurance companies? So far I've had Anthem and Aetna say that their members would not be charged, or that they would be waiving that for their members.
Yes, most of them right now are creating that policy. And so specifically any kind of healthcare treatment regarding, you know, diagnosis and treatment of the virus, or, you know, provision of services through telehealth, teletherapy, those are the ones where those copays and deductibles are being waived.
Okay. Are you, do you have any place on the OPA website where you're collecting that information by chance?
The information about the copays and the deductibles?
Yeah.
Probably the only place where that should be is in my blog, and I can tell you I don't think it's there.
Okay.
So, but that's a good note for me that maybe I should go ahead and include that as I'm coming across. I'll tell you what I'll do. Next time I get around to an update, which will probably be by the end of the week, I'll backtrack and see if I can include some of that information there of the ones that I've heard from. Because I do have the information. I just haven't included it in my updates.
Okay. Yeah, that would be great. We have a system where we can just automatically charge a copay as soon as the appointment's done.
Yeah.
And I'm thinking I may need to just turn that that off for now, or at least with certain insurance companies.
Yeah.
Okay, thank you.
Mm-hmm. I'll backtrack and see if I can do that.
Thank you.
Have we covered all the bases?
Jim, there's one thing I wanted to add, somewhat scenario, and maybe obviously for future context, but I think when we were talking about, you know, best practice standards for telemedicine, I would like to maybe suggest we expand that a little. I've been talking to some of my colleagues briefly about, it would really be helpful for me to share with some of my colleagues ideas, because there's such a pervasive issue right now is how do you help people with anxiety about the coronavirus situation? I know APA has a list of helpful things and so forth, but it really is a clinical challenge. You know, I sort of see it as whatever issues people had, this is now added to the mix. And there's obviously no single approach, but I'd love to just have a forum where we could kick ideas and what people.
Yeah, I think that's great.
Yeah.
I think particularly my clinical experience is that particularly for those people who had, you know, anxiety issues to begin with, you know, it just kind of exacerbates that considerably. But I think that's a great idea.
Yeah.
Dave, if you want to, typically I would just sort of move forward with getting that to the right people, but I'm overloaded right now. So why don't you maybe reach out to, you're pretty well connected with some of our other leaders. Why don't you reach out to one of our other leaders and maybe make that suggestion as a potential forum. Michael's on this call too, and maybe he'll hear this too and be able to make a note of that. But I think it's a really good idea. We do, now you are aware of the other forums that we're having that focus on, you know, some self-care and, you know,
we had one on social responsibility on Sunday and helping people with basic resource needs at this time.
I think what Dave is suggesting is just have a forum like this just to bat around like coping ideas. Which I think is great.
Yeah, I've been noticing in some of my work with clients that as we talk about the pandemic and how it's affecting clients, um, it ends up kind of tying into their core issues or what we might have been working on anyway.
Yeah.
The way they're responding or the way their families are responding. And so it's been sort of a vehicle to discuss what's happening, but also further the work I'm doing with them individually.
Very true.
There was an interesting piece on NPR the other day about how a lot of people are just feeling grief because of the pandemic. It's changed our whole way we do things and what our lives are like, and they feel a sense of loss.
I think that's true. And I think for those people who are a little more disposed to anxiety, to react with anxiety, my experience has been they're reacting with anxiety to some of the huge changes that are happening.
Absolutely. And the other thing I see is the issue, kind of this happening in the era of social media and information overload. If there is one piece of advice I'm giving patients is limit your exposure to the news and Facebook. Because at a certain, and in fact, it's actually interesting. I'm kind of working on this idea that one of the reasons this came up, that I'm finding some of my patients who have been dealing with their existing issues had to do with chronic medical problems, chronic pain, actually seem to be dealing with this better than other people. And part of it is, we've talked about it, is they've gotten pretty good at compartmentalizing, learning, I have a problem that I can't fix, so deal with it the best you can, and then try not to deal with it from that point forward, which turns out to be perfect coping for this. In other words, you need some information and you want to do your part correctly, but you don't want to obsess. So, but I do find, a lot of people are just, way overdosing on information and conspiracy theories and every other thing. And especially the ones who had pre-existing anxiety issues, this has been gasoline for the fire.
Especially with people that are anxious and tend to be ruminative. You know what I mean? It's like they think about other things extensively, and so they would think about this extensively too, and load up on the news, and then which adds to their anxiety and adds to some of the stuff that brought them into therapy in the first place.
So Dave, just to be clear, what I see on Facebook, I shouldn't listen to?
Well, there's an old saying about what percentage you believe of what you read and what you hear. And I would say multiply that times 10 for Facebook.
Got it.
I would add that this is not just our clients, this is us too.
You're right.
Okay? And so the way it's manifesting in us are all these, the misinformation and the ideas that are flying back and forth, and somebody gets a bit of information here and wants to post it on the listserv, and it's completely misleading. And I think some of that is an anxiety reaction and an attempt to have some kind of control over the circumstance. So we do that. We're doing that too. But it is probably my biggest effort at this point is to have meetings like this, so I'm getting you as accurate and clear information as you possibly can. And so now everyone here can in turn just help me disseminate this information so that we have some kind of stability in terms of like the right information that's out there and available.
Another take I'm having on this is it's giving me and other people I know an opportunity to get to know themselves better, and be in the here and now, because we're so preoccupied with our daily routines and how busy our days are that you rarely get a chance to look at yourself. And I always like to look at the positive side of everything possible, and that's what I'm doing. So I'm asking my wife for feedback. I'm asking her to give it to me in pieces about me. That's a joke. She's always willing to give me feedback about my flaws. So, be brave and allow it and accept it. That's what I say. That's my philosophy anyway, one of them.
I think the other piece with clients who are isolating is to really try to help them stay in touch with their friends and family. I think it's
Right.
really easy as you're isolating to just do nothing and maybe then binge on the news or on Netflix or whatever. But the importance of staying in contact with people that you have relationships with, I think, is really crucial.
Well, Marilyn, it was a tad spooky. A couple months ago, I had started reading some literature basically they've identified a new risk factor for illness, health, premature death, which is about as powerful as smoking in terms of predicting negative health outcomes. And it's particularly powerful in the elderly. And you know its name because you've been hearing it nonstop. It's called social isolation. In other words, isolating people is very unhealthy. And yet now the healthiest thing you can do is to isolate. And I'm seeing a lot of our group behavior dynamics in humans is people saying, I know I should isolate, but I feel like I'm depriving myself of something I need desperately. I notice if you go to the grocery store or whatever, people are desperate to talk. Strangers will talk to you for an hour if you let them. And I think that everyone's just feeling the absence. And, somewhere is that balance point of your risk of exposure versus your risk of isolation. And it's not an easy place to find. And I think some of the really irrational behavior you're seeing of people, having parties and so forth is, again, an overreaction to that.
One of the pieces we've seen in our clinical work at the Counseling Center at Cleveland State is that we had more people participating in our group therapy after we got back online and had our groups up and running than before we had spring break and the isolation starting. So I think if you're inclined to do group therapy and you can get paid for that, this might be a really good time to have some groups online through online platforms.
Well, this discussion is a perfect example of what we're talking about. I don't think I've met any of you. I don't think. And this, I'm starting to feel better. I mean, my wife's downstairs on the phone right now. We have a study group that we meet every Tuesday night, and you guys got picked. I mean, I left them in the dirt to have this, and I'm really glad that I did. This is part of the solution. And I do have clients that are telling me stories about lobbing phone calls or getting on Facebook and just connecting people in their community or in their family they haven't talked to for a long time. And there's one family that I've worked with for a long time, medically fragile kids since birth in Cincinnati, and it's amazing the kid's still alive, but it's been enormously difficult, as you can imagine. And so this whole thing hits, and I'm working with the mom, and she comes on the phone and she's ecstatic, and I said, well, what's with you? She goes, I live this stuff every day. I mean, this virus stuff is nuts. My son could get this. We've been living this for 13 years, and I finally feel like I have some company. I would have never thought of that. So it's just one of the interesting connecting things that's happening. Is kind of on the upside of this whole thing.
Dan, what do you think, what about this gathering is helping you feel better?
Well, I'm the only psychologist in my practice, so I mean I own it. So, and these are great folks, but I just don't. We've had some CEUs here locally, but they've all been canceled recently. I was kind of looking for them, especially because they were get my ethics requirements in. But it's just been kind of alienating. I mean, I love these mental health people that I work with, but this feels like camaraderie to me.
So it's the connection with others, with your fellow professionals.
I can add to that. This is Lynn. I'm in a solo practice. And so, being able to see a bunch of faces in conversation is very uplifting to me as well. And Jim, we can't thank you enough for the efforts that you and your team have put in, and the staff as well. Just heroic amounts of time that you have devoted to us and our practice. And I can't thank you enough.
Amen to
I'm
that.
so appreciative. Yeah.
I don't want to toot your horn, Jim, but let me do it for a minute. Jim does so much behind the scenes. When I joined this committee, I was amazed at what the guy can handle, and he gets things done. He gets results. I love results. That's why I look up to him quite a bit. This guy, he gets it done. So does Dave Schwartz, I have to admit. So some great people with OPA, for sure.
Thanks for the recognition. At the end of a tired day, it uplifts me. People send me little notes, and that really does uplift me too. Thanks.
And thank you as well, Matt. I was just going to share a thought. I was on a call for the professional practice committee Saturday, and we were talking, and they actually asked me to kind of, I was new to the committee, and they asked me to kind of bring people up to date on, what has the BWC task force been doing, and what are you doing now? And I couldn't help it. I just cracked up laughing, and they said, why? And I said, you just reminded me of a phrase that I heard once and I use so much in my life and my practice. And the phrase is, with apologies for the language, when you're up to your ass in alligators, it's so easy to forget the original job was to drain the swamp. And we're just going to be seeing a lot of that right now. It's like, we had some long-term goals and ideas, but boy, right now there's things we got to deal with now, and we'll get back to the swamp when we can.
Dave used that phrase in a meeting that I was in a few days ago, last week, I think it was. And I said, hey, Dave, I'm up to my ass in alligators.
Yeah, I think I'm somebody who loves, change management and overseeing change, but I've never had to do it quite so quickly under so much pressure before, and it was very intense and exhausting. And for those of you who are trying to make these changes really quickly, I feel for you. And I think the exhaustion is from grief, and also from overwork, and also from honestly trying to learn the technology pieces, which maybe are not our normal wheelhouse. That can take a lot of time and energy. So give yourself time to learn the technologies.
And this also can be inoculating, what can really match this in the future? I mean, I'm sure there are things, but they'll obviously prepare you or us to do, to handle change, unwanted change, abrupt change.
So I want to say a couple things about our meetings here. These are being recorded. I guess I should have said at the beginning. These are being recorded, and they're being posted on YouTube for other people to be able to hear, because a lot of times people's questions will get answered if they can hear our conversations here. So, and I think that a lot of people are saying that this feels very validating, and it feels like gives them some real support. And so I think what we really want to do is keep these rolling. And so I would ask you, if you've signed up for this and you've been a part of it, don't sign up for another one, because we can only allow 50 people in at one time. So if you the main points of information you're hearing right now, if there's a question that you have after this, send me an email. But if you don't sign up for the subsequent ones, that gives someone else room to be able to come in and have this experience, because we have a lot of members. We can only do 50 at a time.
Jim,
Yeah.
real quick, I forgot to recognize Michael Rainey too. He gets a lot of stuff done, but I think he does a little more quietly. But he is definitely a rock star behind the scenes too.
Yes.
I just wanted to add my thanks before we leave to Jim and Michael and the OPA staff, Karen and Carolyn, and all of the staff for the amount of support and the clarity of information and helping us navigate through these uncharted waters. You know what I mean? It's kind of like that a map or a road map to help us get through. So thank you guys for your selfless service to the Ohio Psychological Association and to all the psychologists. Thank you.
Thank you.
All right. Well, I appreciated also just hearing ideas for future forums that we could market differently as like clinical issues in starting telepsych practice, things like that. We'll kind of look to see what capacity we have to do those over the next month. So we can watch for differently marketed forums and look to join those. Okay, well, if that's it, it looks like everyone is saying their thank yous and their stay wells. Thank you again, Matt and Jim, particularly for working through the exhaustion. I hope you get some rest and some good self-care time coming up.
Thank you, Catherine. I forgot to mention you too. I'm sorry. I told you I was going to be fumbling a little bit today, but
No, you're
everyone
fine.
at OPA, it's excellent. I mean, we got to increase our membership, because people, I don't think they understand the benefits you get from it.
Okay, well, everybody stay well. Take good care of yourselves.
You too. Thank you.
Stay well.
Right.
Everyone
Good
take
night.
care.
Everybody.
Thank you all for participating.
Good night.
Good night all.
Good night.
Bye.
Good night.